कर दिए। आईडी सही है ना, मैक्समो @ID टॉपिक ये आईडी। अमित, लाइव कर दिया।
Good morning, everyone. Uh, there were 13,000 OPD cases in hepatology, 843 admissions, 1,634 procedures were done, and 181 SU admissions and 48 deaths during the month of December. This is a case report. She's a 28-year-old female with no prior comorbidities. Her index event was in November 2025 when she had history of prodrome, vomiting and abdominal pain for 1 week with a history of jaundice, maximum bilirubin of 4, for which she's taken homeopathy for 1 week. In December 2025, her jaundice was improved. In January, she again had worsening of jaundice, abdominal pain, and distension, for which she was admitted in an outside hospital for 4 days. During the last day of admission, she had altered sensorium, for which she was intubated and put on mechanical ventilation and shifted to ILBS. On examination in the ER, her heart rate was 62, BP was 110/70. She was febrile with an RBS of 85. Bilateral pupils were reactive. Her abdomen, liver was palpable. Free fluid was also present in the abdomen. Equal air entry, no added sounds. IVC was 14 by 17. Her pH was 7.48. Lactates were 4.3 and RBS was 126. Outside investigations show that her bilirubin was 15.96, gradually increased to 19.5, with a maximum INR of 11.29 and ammonia of 240. Her HAV IgM was positive outside, and her ANA and PMSGL was also positive outside. So the working diagnosis of acute and chronic liver failure was made. Acute being probably hepatitis A virus related with superadded drug induced liver injury. Chronic being likely autoimmune hepatitis related because she had ANA and PMSGL outside positive, and organ failure in the form of cerebral and coagulation. Cliff score of 47, ARC of 13, and MELD of 32. In the imaging, CT brain was done, which showed diffuse cerebral edema. CT abdomen was done, which showed ascites, splenomegaly, and also features of chronic liver disease. So the plan was to start her on IV antibiotics. Transplant call was sent, and expedition of workup. To start her on extracorporeal therapies until transplant, and regular monitoring of prognostic markers. On the day one in admission to ICU, her urine output was 40 ml with a MAP of 95, ammonia of 310, and INR of 2.5. Lactates were 4.5. So EEG was done, which was suggestive of encephalopathy. Surgical transplant call was done, but they did not have any donor at present. So the advised donor identification map of she had persistently high ammonia with 252 and INR of 2.52. Lactates were non-clearing 3.2. So the issues that she had were persistently high ammonia, ALF-like clinical picture. There were no available donor for liver transplant and non-clearing lactates with conservative management. And she had rapid worsening of the disease. The second day, because she had no available donor and ammonia was persistently high, she was started on CRRT and dose was increased to 20 ml per kg. Ammonia reduced with 192, INR of 2.6 and lactates were 2.2. Her ET biofire was positive for Klebsiella pneumonia. NDM and OXA48 resistance was also detected. Her repeat INR was 4.3, so her low volume plex was initiated, after which she developed bradycardia and erythemia. She was reverted with CPR and shock, post which she was initiated on triple vasopressor support. Her PF ratios also worsened. Urine output decreased to 5 ml and lactates were 8.4. Ultrasound Doppler was done, which showed a reduced flow in portal vein. So suspicion of acute thrombosis of portal vein was suspected. So we wanted to rule out a CT pulmonary embolism that might have caused the arrest. So CT pulmonary angiogram was done, which showed no evidence of a pulmonary thrombus, which showed features of bilateral pleural effusion and moderate ARDS. Her miniball culture was also growing Klebsiella, which was sensitive to ceftriaxone, sulbactam, and colistin only, and antibiotics were upgraded accordingly. The next day, her ONST was 5.1 and 5.5. Urine output was decreased to 5 ml per hour. She was on triple inotrope support with a MAP of 100. Ammonia was elevated 357 and INRs was 1.93, although the sample was post-plaque sample and lactates was 6.9. 2D echo was done, which showed severe LV systolic dysfunction with a reduced EF of 15 to 20% only, and LV global hypokinesia. RV contractility was normal. So she was started on dobutamine infusion. Uh, EEG was also done, which showed flattening of waves and diffuse slowing. She was not able to tolerate CRRT. Through the course, she had worsening of shock, PF ratios, and lactates. And ONST was also variable from 5.5 to 5.7 mm. Urine output gradually became nil. Ammonia was elevated. ANA was more than 11, and lactates were not clearing. She then developed sudden cardiac arrest, and she couldn't be revived. In the investigations here, her hepatitis A was reactive. Other hepatotrophic viruses were negative. Autoimmune liver profile showed SLA was positive. IgG was elevated to 22.4. Her blood culture and urine culture were negative. Her minival culture growth Klebsiella. Fibrinogen was 114. PCT was negative. LDH was 566. CRP was 7.9. So the probable cause of cardiac arrest that she might have had was because of electrolyte abnormalities. Since there was a sudden cardiac arrest post-plex and she was already on CRRT, but there was a completely normal ABG prior to the post-plex sample, and that goes against this cause. She could have had arrhythmia secondary to cardiac dysfunction. There is severe systolic dysfunction, severely reduced EF, and worsening shock, but there was no prior history of cardiac abnormalities. She must have had a brainstem compression because persistently high ammonia levels, even cerebral edema at presentation only. EEG activity post-arrest showed diffuse slowing, and ONST after the event is also favoring the probability. But there was no definitive evidence on imaging that we've done prior. So the role of plex in ACLF. In plex with ACLF with single organ failure, in case of brain misfunction, therapeutic plasma exchange can be used as as a bridge to emergency liver transplant. In ACLF with multiple organ failure requiring organ support, CRRT and plex can be used, which can be assessed after 3 to 7 days. If the recovery is less than 3 organs, then you have to go for emergency liver transplant. In patients with ACLF, the number and type of organ failures with not the MELD score may reliably predict overall outcomes. Although emergency liver transplant in patients with ACLF with a MELD score of more than 32 and ARC of grade 3, pulmonary plasma exchange should be used only as a bridge to liver transplant. Another study shows that although plex improves short-term mortality, the long-term benefits are not seen. In a study that is done recently, it showed that the outcome of plex in ACLF after 180 days, there were about 68.2% deaths at 180 days. The adverse events post-plex, it is graded according to mild, moderate, and severe and rare. The mild is when this tolerated without medication. Moderate, the need of medication due to an adverse effect. Severe, it has to be interrupted due to the adverse effect. And death is after plex. Adverse effects are mild in 2.4%, which can be tingling, numbness, moderate in 3%, and severe in 0.4%. Only syncope and hypertension, 32% of the severe adverse effects. Urticaria 17 with fever and 8%. Arrhythmias or asystole are seen in 4.5% of the severe group of adverse effects. More adverse effects occur during the first procedures versus the subsequent procedures. With 8.4% during the first procedure of therapeutic plasma exchange. Hypotension was most common if albumin was used with the replacement fluid, and urticaria when plasma is used. Arrhythmias occurred through similar events when using plasma or albumin as replacement. In 64% of the procedures with bronchospasm, plasma was part of the replacement fluid used. There can also be other severe adverse effects like citrate toxicity. Hence, RCA is the ideal method. Citrate is a calcium chelator and is used by most centers for anticoagulation. As citrate is metabolized by the liver, there is a concern of citrate toxicity in patients with liver failure. It manifests as symptoms of hypocalcemia. The guidelines recommend the targeting citrate concentration between 1 to 1.8 mg per kg per minute. Prophylactic calcium supplementation during plasma exchange with calcium monitoring helps prevent hypercalcemia. With low volumes of plasma exchange, the chances of hypercalcemia are quite less. There can also be severe adverse effects which are delayed, like transfusion-associated lung injury and transfusion-related circulatory overload also. In cases of sepsis and plaques, according to the American Society of Apheresis, plaques is categorized as grade 3, category 3, grade 2A intervention for sepsis with multi-organ failure, which reflects that this role of plasma apheresis in sepsis is not yet firmly established. Its use should be guided by individualized judgment, which is supported by weak recommendation. The efficacy of plasma exchange primarily works by two key mechanisms in sepsis. One is the infusion of fresh plasma and removal of harmful mediators. In principle, it ameliorates sepsis-induced organ dysfunction and improves prognosis through multiple pathways, although at the risk of blood transfusion-related injuries, electrolyte abnormalities, and arrhythmias also. So the issues in this patient were persistently high ammonia, high INR, and hyperlactatemia. The extrahepatic manifestations like heart failure with reduced EF, probably stress-induced cardiomyopathy, ARDS, poor PF ratios, and sepsis. In cases of severe hepatic dysfunction, the early identification of cause and etiological workup, expedition of liver transplant workup, and early initiation of bridge therapies like CRRT and plasma exchange. Hepatic encephalopathy, the quadruple H therapy, which is hyperventilation, hyponatremia, hypothermia, and hemodiafiltration like CRRT. Their use is a bridge to transplant to prevent persistent hyperammonemia. In case of ARDS, early sepsis control, airway protection, and elective intubation to avoid Raleigh and neuroprotective ventilation protocol should be used. And sepsis, early control, BioFire assays, resistant-based antibiotics, and culture-based modifications should be used.
What could we have done better in this part of the presentation? Could we have done anything better to say? Could
this patient, although fulfill the criteria of ACLF, but has unique challenges like the patient has cerebral edema, baseline INR was 11, and persistently high ammonia and lactate. So she has ALF-like features in ACLF, but with the diagnosis of ACLF. So upright, we had the transplant call, and the patient they do not have any living donor available. So considering the illness and progressive liver failure, we went ahead with the CRRT for decreasing the ammonia and hemodynamic stability, as well as the flex was done. So this was done, but despite that, post plasma exchange, she had rapid deterioration with new onset shock and cardiac dysfunction. So probably the arrhythmia may be the cause of this.
comments, Dr. Sood, why we had sudden death post plasma exchange and from Minu? Is Dr. Sood there?
Sorry, sir, I didn't.
This patient had a plasma exchange, and I think 20 minutes or an hour after, if I remember well, the patient died and had cardiac arrest. Am I right?
Yes, 20 minutes post.
So we do plasma exchange a lot, but what could we have done wrong, or could we have missed something in reading?
When we are following the standard procedure, unless we see some definite arrhythmia or something, I have, in fact, right now, no comments, and I can't really say much. I mean, if there's arrhythmia, then we have to manage properly. Arrhythmia is the only thing. Patient did have hypotension, but that is
He's just 28-year-old, am I right?
Yes, sir, 28.
And we had plasma exchange, and within an hour, she had cardiac arrest.
See, the only thing is maybe having cirrhotic cardiomyopathy. That's the only thing I can think of. Otherwise, arrhythmia, most likely in the setting of the ICU, is the electrolyte imbalance and all those things which may be predisposing to the arrhythmia. Otherwise, with a normal cardiac functions, difficult to explain why sudden cardiac arrest.
Yeah. Any comments, Rakhi or anyone? Okay, Vaishnavi.
Morning, everyone. Good morning, everyone. I'm Dr. Ravi from SPV Surgery and LT. Today, I will be presenting morbidity and mortality for the month of January 26. We have data for December 2025 and 2026. We performed total of 26 transplant, which included 24 LDLT and 2 DDLT. In 24 LDLT, 6 pediatric transplant was done, and 1 LDLT was done in AIIMS Bhubaneswar. Elective surgery, total of 105 elective surgery was done, including 7 major hepatectomy and 6 pancreatoduodenectomy. 3 Kasai procedures were done, and 2 PSRS was done, including other surgeries. Emergency surgery, we performed 10 emergency surgery, including exploratory laparotomy, 7, and 3 tracheostomy. Morbidity, January 26. Mr. AG, 34-year-old male, underwent right lobe living donor liver transplant on 16 January 26 for CLD ethanol. He has a MELD of 24. In post-op period, he developed graft dysfunction with coagulopathy, leading to raised lactate, and patient developed shock, for which inotropes was started, and he was later intubated and also had multiple episodes of hypoglycemia, for which then he underwent surgical tracheostomy, and for liver support, he was started on CRRT, and 2 sessions of Plex was done. Patient is currently in ICU. Mortality. Baby SP, 1 year 8 month male, underwent living donor liver transplant, left lateral lobe graft on 15th December 25 for CLD biliary atresia, and in post-op period, he had a graft dysfunction, clinical rejection, and he was re-intubated and was on ventilator, and he later expired on 10th January 2026. I will be discussing this case later. Miss VD, 73-year-old female, underwent a staging laparoscopy followed by extended right hepatectomy with caudate lobe resection with hilar lymphadenectomy and portal vein resection followed by into-end anastomosis with Roux-en-Y hepaticojejunostomy on 3rd January 26 for hilar cholangiocarcinoma, bismuth type 3A. He in the immediate post-op period, she developed refractory shock, and that later she had MODS. She also had in the later period respiratory failure secondary to bacterial plus fungal pneumonia. And she later expired on mortality. Today I will be presenting case of baby SP, 1 year 8 month old male, had a body weight of 9 kg. He has term delivery with vaginal term vaginal delivery and has a birth weight of 3 kg. No history of an ICU stay, and immunization was complete as per the age. History. Patient has jaundice since first week of life associated with high colored urine, and later in AIMS he had liver biopsy and was diagnosed with biliary atresia. He also has multiple episodes of hematemesis. Initial was in April 2025, for which EST was done at AIMS Delhi. Then he presented to ILBS, was evaluated for liver transplant, and initially was planned for ABO incompatible LDLT, for which rituximab was also given in August 2025, but still the titer was high, and family was explained about the need for plasmapheresis, and they were not willing for ABO incompatible LDLT. That's why they later came with ABO compatible donor, and then LDLT was done. Pre-op issues. Patient has history of multiple episode of UGI bleed. He also has had atrial septal defect, for which device closure was done on July 2025. He had left humerus hairline fracture from trivial trauma in October 25. Last admission was in October and November 2025 in LBS. At that time, UGI was performed for varicose. UGI screening was done, and during the screening, he has desaturation and bradycardia, for which ICU stay was required. Pre-operative investigation, CBC platelet count of 95, and bilirubin was of 27, AST/ALT 323 and 151, NR was 1.4 and albumin 2.5. His pre-op cultures had no growth, and fitness was obtained from cardiology and pulmonology, and CCT was done, which showed CLT with portal hypertension, no PVT, and as well was there. Portal vein was atretic, minimal free fluid was present, and dilated inferior mesenteric vein, which was supplying rectal varices. So diagnosis was CLD, biliary atresia unoperated, portal hypertension, prior bleeder, grade 3 high risk esophageal varices with RCS, and also had GOB1 and GOB2 varices. Decompensation had jaundice, growth failure, and HPS. PELD was 21 before surgery. Donor detail, Miss UD, 52-year-old female, was blood group of O positive, was aunt of the patient, BMI of 18.3, no prior comorbidities, and history of open hysterectomy. Had LAI of plus 13.3, and fibroscan was normal. Liver volumetry was also okay. Her anatomy was classical anatomy, and issue was she had high absolute eosinophil count, and eosinophil was percentage was also very high, 34% eosinophil, for which she was treated for filariasis at ILPS, and then eosinophil count improved to 7%, and absolute count also improved to 780. But IgE was 718. Patient underwent living donor liver transplant, left lateral lobe graft on 15th December 2025. Intra finding were minimal ascites, large hard cholestatic liver, and large HDL lymph nodes was present. Outflow, hepatic vein graft, left hepatic vein was anastomose to common orifice. Graft left portal vein was anastomose to main portal vein of the recipient, and left hepatic artery was anastomose to recipient left hepatic artery. Biliary anastomosis, Roux-en-Y HJ was done, single duct single anastomosis. Cold ischemia time was 67 minutes, and warm ischemia time 23 minutes. Graft weight was of 304 gram, and GRWR 3.3. No blood transfusion was required intraoperatively, and intraop Doppler was also normal with portal flow of 1 liters. Intra-op event, inferior mesenteric vein was ligated. Histopathology shows explant liver cirrhosis, biliary atresia related. Post-operative course, patient was shifted to transplant ICU on ventilator, and inotropic support was there, and shifting lactate of 1.4, and Doppler was normal. On POD1, patient was extubated. X-ray has right upper lobe collapse. On the evening test of post-operative day 1, his transamnitis increased to 3600 AST and ALT of 2823, and the patient also has a fever episode for which antibiotics were upgraded. In view of severe high transamnitis, Doppler was done, which was normal, and CCT abdomen was also done, which was normal. Lactate was normal on POD1, and in view of history of filariasis in the donor, patient was started on DEC prophylactically, and then peripheral smear was sent early morning, which was negative for microfilaria. On POD2, tests were started to improve, and NGORS started, and chest X-ray mild right upper lobe infiltrates was there, for which HFNC patient was on HFNC, and lactates were normal, urine output were adequate, and intermittent fever spikes were present. Pre-op and day 1 cultures were no growth, and Doppler was normal. On POD3, patient has high grade fever of 104 and bicytopenia, for which cholesterol was added, and antifungal was upgraded to posaconazole. Patient also has loose motion, for which cfDNA was sent, and injection ganciclovir was started prophylactically. And EBG was acceptable on that day. POD3 cultures were also normal, and Dopplers were normal. On POD4, also fever spikes were there, but decreasing in intensity. Bicytopenia was present. AST, ALT were improving. Immunosuppressant was held in view of fever, and injection hydrocort was given. On POD 5 and 6, there was again jump in AST ALT to 2100 and ALT to 1900. Rejection was suspected, and the patient was given MPS pulse. Patient lactates were increasing. Peak lactate was 10, and there was increasing oxygen requirement on HFNC. Patient had metabolic acidosis, for which bicarb infusion was also started, and patient has sensorium was decreased, patient was drowsy, so ammonia level was sent, which was high, 303, and but CCT was done, which was normal. Then POD 7, in view of error finding, patient was reintubated. On POD8, acidosis was persistent. Patient has abdominal distension. In view of suspicion of graft congestion, laparoscopy with Bogota bag placement was done. After that, on POD 9 to 11, patient had coagulopathy. Drain output were high, and lactate was persistently high. And the patient also developed septic shock. Blood culture was sent, which had growth of Klebsiella, for which antibiotic where tigecycline was added. And the patient also has multiple episode of bronchospasm, which was managed. And then transamnitis was there, and patient then developed bilateral pneumonia, which was managed. Patient FiO2 requirement increased in view of pneumonia, although ET culture was negative. And patient had respiratory acidosis, which was managed by changing ventilatory parameters. Patient then also had right side pleural effusion, for which ICD was inserted. In view of ileus, NG feeding was stopped. Blood culture has Klebsiella, and drain culture had also Klebsiella. On POD 14, a surgical tracheostomy with Bogota bag change was done. Graft function slowly improved, but patient had recurrent episode of spasm, and ET secretion was thick, but culture had no growth. On POD 15 to 19, ventilator dependence was there. Patient was AFib, was on a hydrocot. Cultures were then started to become negative, and patient was tolerating NG feed, and Doppler was within normal limits. POD 21, patient has active bleed from NG, for which resuscitation was done, and blood products were transfused and coagulopathy corrected. Patient has increasing lactate and metabolic acidosis. Pent-up infusion was started, and